Right, so it's some people will remember Padraig and Sean who escaped before the pandemic. Well, when did you actually?
July 2020. So the
official
of the pandemic.
yeah. So they never had a leaving date, and they've been applying Mendelian randomization to healthcare costs in many different settings, and they're going to talk to us about that.
Great. Thanks very much, George, and thanks for having me back. So I'm going to be talking about some work I've been doing as part of the Integrative Cancer Epidemiology program with Sean and Richard, which is bringing together some strands in that program and some prior existing ongoing work in the IAU. And quick overview of what I'll be talking about. So developing cancer drugs is expensive. It's believed to be expensive. The therapies that are ultimately developed are certainly expensive. And if we want to deliver reasonable, cost-effective care to cancer patients, then it's very important to demonstrate the value of those interventions. And we used Mendelian randomization for the first time to understand how cancer exposures influence healthcare cost and quality of life, which are the two key variables we need to make claims about value, cost effectiveness. And then we did something new, which is to use those estimates to simulate a novel hypothetical prophylactic population-wide cancer intervention based on a repurposed drug. And briefly previewing the conclusions, it is feasible to do this with Mendelian randomization, hopefully in an efficient way, alongside other evidence we might triangulate in this space. So this is a graph showing the cost of new cancer drugs over the last 60 years in the US. At the time, they were approved by the FDA. The vertical axis is on a log scale, so drastic increases over time. Looking at that in a different way, if you look at the cost of anti-cancer drugs against median household income in the US, which is, might surprise you, has been pretty much flat since the mid-70s, but the price of cancer drugs has been increasing, and then about 20 years ago, it really took off. So these drugs are certainly expensive. And one reason for that might be that these drugs are getting better, which would be potentially justifiable. But there's actually very little evidence that cancer drugs as a whole are indeed getting better. So this graph shows overall survival in months for 71 drugs for metastatic advanced or refractory solid tumors, and median survival, overall survival, is only 2 months. So despite the incredible increase in cost, the quality, at least if you measure by overall survival, was static in this period. This is a different way of showing something similar. This is, these dots are a composite measure of efficacy, safety, quality, consistency of cancer drugs against price. The R-squareds here are essentially zero. There's no association between what people are charging for cancer drugs and their quality. So that seems to be a problem in this market. And of course, the claim is often made that this is because it's very expensive to develop these drugs. And, you know, of course, it's complex, it takes a long time, you know, study design, doing a mouse model, then testing it in different phases of trials. You know, you're talking about 20 years. The evidence on this actually is not very clear that this is a very good excuse or rationale for how expensive these drugs are. And you could think about this in two ways. So this is William Stanley Jevons, who's an economist in the 19th century. And it used to be the only way you could get pearls as jewels was if someone died for them, which is a very expensive, risky thing to do. So people had to train, you have to hold your breath. It's a difficult thing to do. So he said, are pearls expensive because people do this risky, difficult, challenging thing? Or are people doing this risky, difficult, challenging thing because they know the reward they get when they sell the pearls is high? And I think there's a good case to be made that people are spending a lot of money because they know ultimately they will be able to charge a high price, which is a different issue than saying these drugs are expensive because the cost is high. And the evidence on this isn't very good, but if you look at the relationship between research and development spending and the revenues, you would say that there is no connection. So that would say that people are diving for pearls because pearls are expensive. It's not that pearls are expensive, because people dive for them. But a way of getting around this would be if we do some drug repurposing, which would leapfrog a lot of the developmental stages which are associated with high cost. And if we could efficiently get to drugs that we know are safe, then we're going to speed up how quickly these drugs come to the market and perhaps reduce their cost as well. So that's one aspect of efficiency I'll be touching on, but also even, is it such a bad thing if society is spending a lot of money on cancer drugs? And it is in the sense that the money that we spend on these drugs will ultimately be displacing money and therefore care that we could give to other people. So this is Archimedes displacing water in his bath. And this is the idea of opportunity cost, that we are displacing other care when we spend too much relative to value, in a sense I'll define in a moment, on particular types of drugs. So this picture on the rise appeared in the 2010 Conservative Party manifesto for the general election. David Cameron became Prime Minister. He set up a cancer drug fund, which was essentially paying or subverting the existing process in the NHS to assess the value of cancer drugs specifically. Why cancer? Well, people seem to have a particular fear of cancer, the emperor of all maladies. So let's fund new cancer drugs. It was a vote winner. But you can measure, quantify the opportunity costs associated with overspending on these drugs. And there's good evidence it probably reduced population health by a very, very significant degree. So that's why we need to be thinking about these issues. And you can think about a health system as a black box or a machine. You put money in, say £20,000, and you want to get some health in exchange. What's health? Well, you could think of it as the quantity of life. And in the NHS in principle is reluctant to spend more than about £20,000 to get one quality adjusted life year. So if you're spending more than £20,000 to get quality, we might say you're displacing healthcare elsewhere in the system and therefore reducing population health. The opportunity cost of your intervention is too high. So what we need to make claims about the value of cancer drugs are figure on cost. So what is the cost? Not just the drug itself, but everything downstream of the drug, and some sort of measure on health, which we're going to talk about in terms of quality adjusted life years equalities. If we estimate this in a sort of naive, conventional way, look at the association between cancer, say healthcare costs or quality adjusted life, of course, there'll be confounding variables. If we naively estimate the association between cancer and this health outcome, when the true relationship is also a function of these other emitted variables, then we get an estimate that's a function of the bias, which is caused by the association between these emitted variables and the thing we're interested in, which is a particular cancer exposure. So you know the punchline I'm building up to. So trials would be ideal, but even if you could do a trial, you might want to think about evidence you collect in advance of doing the trial to prioritize the target, the design, or if you've done a trial and you want to extrapolate the findings over the long term, what would you do? So a typical way of addressing this is something called Markov modeling or discrete event simulation, where we would model different states, different downstream events associated with a particular condition, and then add up how long people stay in different states, and then you can get an estimate of cost effectiveness. A challenge with this, even if you can get the data to populate these different states, is structural uncertainty. So if you're modeling the effects of an intervention for breast cancer, are you modeling all the distal metastatic effects that might come? Do you even know what they are? So that's a challenge. And in this work, we're talking about Mendelian randomization to identify the causal effect of cancers, which is one bit of it, and then also to simulate an intervention without having to have the structural uncertainty of the cohort model or doing a trial based on a repurposed drug. So we're hopefully offering an efficient way of addressing those challenges and some of the excuses that we see for high drug costs. So we did Mendelian randomization. So with that restriction on the type of cancer and using UK Biobank as the outcome, we looked for cancer GWASs that didn't overlap with UK Biobank for any cancer where we could do reasonably, or where we expected there was a reasonable chance of doing sensible Mendelian randomization, which was looking at least 2 SNPs for any cancer exposure with no overlap with Biobank. And the process then led us to 8 cancers. which met our criteria, which were fairly broad. Those were bladder, breast, colorectal, lung, multiple myeloma, ovarian, prostate, and thyroid, and some subtypes of 3 of those cancers, which we used to do additional analysis, but we won't talk too much about that. It's not news to anyone in the room what we need for Mendelian randomization, but just in case you're watching this 25 years from now on YouTube during a coronavirus lockdown, we want our SNPs to be associated with the cancer exposure, independent of those confounding emitted variables, and only influencing the outcome via the exposure. So it was all fairly standard and straightforward in terms of the Mendelian randomization. We created polygenic risk scores based on the effect size in the respective GWAS. We looked at the standard heterogeneity statistics to see if there were potential violations that would show up, violations of the exclusion restriction, the third assumption, that would show up as heterogeneity in Cochrane's Q statistic. And we did some standard sensitivity analysis using the over-identified models. So those are models where we have more SNPs than exposures, which is essentially everything. In biobank, we get our cost data from hospital episode statistics, and specifically the records of inpatient care, which we've converted into healthcare cost. And also at the time of this analysis, 38% of primary care practices were linked to biobank. The fact that it's incomplete is because of different systems of primary care IT systems. But we did some imputation to account for that. And cancer status itself was either or both of records of care, or it was self-reported. And it includes people who had prevalent cancer, so they had cancer before baseline, as well as incident cases post-recruitment into biobank. As I mentioned, the outcome data is from UK Biobank. The exposure, cancer SNP exposure associations were from non-overlapping GWASs. Where there was multiple GWASs for the same cancer, we used the GWAS which was largest, and that tended to be the most recent as well. So then the standard at the time in-house IU treatment of SNPs for linkage disequilibrium and proxies, and standard way to construct polygenic risk scores. So of the 8 cancers included, this is the first 5. And one thing that's worth noting on this slide is the proportion of variance explained by the SNPs in cancer exposure, except for breast on this slide. They're all very low. They're relatively rare cancers. So most of them are fairly rare or have little germline genetic influence, such as lung cancer. So we'll return to this. Proportion of variance explained is low, except for breast and prostate. So for breast, it's 2.5, prostate just over 4%. And obviously for the subtypes of cancer, it's obviously lower than for the main exposure. So cost, inpatient hospital care, primary care costs, a multiple imputation to account for the missing primary care data, just to beef up the amount of cost data we had. Quality adjusted life years are not in UK Biobank, but Sean wrote a very nice algorithm to create them. So what you can do is use known or evidence which describes decrements to quality of life associated with different health conditions, then look through everyone in UK Biobank to see who has those conditions, and then calculate age-adjusted decrements to quality of life. Once you have that, you can calculate a quality adjusted life year. And the interpretation in the Mendelian randomization models is the percentage of a quality change by having versus not having the cancer in a particular year. So they're not cumulative, but they show how your quality adjusted life years will be different did you not have the cancer. And then we also wanted to use these data to assess potential intervention. So this is work from our colleague, Chris Zhang, who did some drug repurposing analysis using Mendelian randomization. So you might have a favorable profile for some disease because you take a drug for it, or because you have a favorable genotype. What Chris found in this paper is SGLT2 inhibitors, so sodium glucose transporters, which are used in the treatment of diabetes, seem to have a tremendous impact. Tremendous might be overstating it, but a very notable impact on the odds of prostate cancer, which opens up the possibility of giving men SGLT2 inhibitors as prophylaxis for prostate cancer. But what he found was this class of drugs reduced the odds of prostate cancer by 71% in the primary Mendelian randomization analysis. And this holds up to a fairly significant degree in replication analysis. So the question we can ask then is, would offering these drugs be cost effective? So on the face of it, it's quite an appealing proposition that you could reduce the odds of prostate cancer by 71%. Relatively common cancer for a drug that's known to be, safe and well tolerated in most respects. You could do a trial, you could do some sort of Markov modeling, but then you have to essentially swallow all the structural uncertainty and all the other challenges of doing that analysis. Whereas what we could do, because we have direct estimates of the two parameters you need to do cost effectiveness analysis, which is healthcare cost and quality of life, we can put this into a Monte Carlo simulation and see if it might be cost effective. So we assumed that every man in the cohort took a particular dose of SGLT2 inhibitors, and we selected canagliflozin just because in trials in unselected populations, well, in unselected diabetic populations, that seems to have a similar impact on HbA1c as in Chris's paper. And it doesn't really matter what drug we assume, it's just because we needed a price, and canagliflozin costs about £470 a year. We assume every man takes this pill. We didn't model the side effects. We're assuming that the comparator in this intervention is doing nothing. So you might be able to, in principle, manage prostate cancer risk by having, good BMI, not smoking, but there's no pharmacotherapeutic agent you can take every day. You can't take a pill to reduce your risk of prostate cancer. So assuming the effect in Chris's trial in relation to the odds of prostate cancer is real, this is telling us something potentially quite useful. So we estimated the proportion of men who develop prostate cancer, the proportion of men who wouldn't have developed that prostate cancer had they received the intervention, so reducing their odds by 71%. And then the healthcare cost and quality impact associated with preventing those men from developing prostate cancer. So we're leapfrogging, the trial, we're leapfrogging the Markov model, we're going straight to the impact of prostate cancer or genetically influenced prostate cancer on these outcomes. And then we can talk about cost effectiveness. So it was a Monte Carlo simulation with parameters for those three quantities. So in terms of the results, our sample had 310,000 unrelated individuals, slight majority of females, mean age of 57 years, and we're following them up for these outcomes for 8.1 years. Median healthcare costs are £600, roughly, so quite substantial. There isn't, prevalence is probably what you'd expect, but 6.6% of women, so that's slightly more than 3% of the entire biobank cohort. 4.3% of men, so a bit more than 2% of the biobank cohort, and then obviously the less common cancers are less prevalent, so as you'd expect. We did a simple linear regression just as a conventional analysis, looking at these outcomes, controlling for age, sex, recruitment center, and the genetic principal components, just to give a little bit of comparability with the Mendelian randomization. Unsurprisingly, you get these very big effects. So big impacts on qualities, so big negative impact, as you'd expect, and big impact on cost, and those are costs per year. When we do Mendelian randomization, as you will expect, especially given the low proportion of variance explained by the SNPs in cancer exposures, you get a lot of uncertainty, except for the more common cancers, breast, prostate, and costs associated with multiple myeloma. But the relatively more precisely estimated cancers do show big impacts as well. The results for the less common cancers probably aren't that reliable. There's probably weak instrument bias. but the F statistics for prostate and breast cancer are reassuring. So then we focused on these more common cancers when we were looking at horizontal geotropy. We did the test for all of them, but the results are concordant using different estimators for breast and prostate cancer. Very little impact of sex, age, and diagnosis time, although as you would expect, if you have an incident cancer after recruitment into after recruitment into biobank, costs are higher because then you're initiating treatment. If you've had cancer before you're recruited, then your costs are a little bit lower. So there is a lot of imprecision, which is something we found and is not at all surprising. The point estimates aren't trivial. So for those more precisely estimated cancers, there is something going on. That's because of the low proportion of variance. Perhaps there's an effect of selection to UK Biobank. Obviously, breast and prostate cancer, men obviously can get breast cancer, but in this case, it's restricted to women. So there is a sex effect in that sense, but not for the other cancers. And as I said, these are both prevalent cases and incident cases. So then if we look at the costs of offering prophylactic SGLT2 inhibition, what we see is we did this by age bands. Obviously, the risks are increasing with age. So, but looking overall, offering the drug to everyone is increasing your cost quite a lot because pill costs money, but it's also increasing quality adjusted life years because it's helping survival. So it's something which we generally see in drug interventions when we evaluate them. They're a little bit more expensive than the alternative, or substantially more, but they're also more effective. So then the question is this a good deal for society to be spending money on this? What we can do is measure the net monetary benefit, which is a function of the rate at which the NHS converts money into health. And this is telling us it isn't. This figure is negative. The reason for this is we're getting relatively little health measured by QALYs relative to the cost of offering this medication, even though it's reducing the odds of prostate cancer quite substantially. But that's life. And it does become slightly more likely to be cost effective, but not meaningfully so as you look at older men. So this intervention would be cost effective if the cost of SGLT2 inhibitors was £32 or less, which turns out to be roughly the same cost as a cheap statin, which is off patent. So it's not inconceivable, although unlikely, that this drug could be cost effective with these assumptions, given all of the qualifications in this analysis, including the fact that we're not modeling, for example, side effects. So if you put this drug in the drinking water, some people are probably going to be suffering side effects from this. We're also not accounting for men who might already be taking the drug for their diabetes. But it is a function of the impacts we estimate using Mendelian randomization of prostate cancer. And if those impacts are bigger on quality of life and cost, as they are for other cancers, but they're just extremely imprecise, so we shouldn't overstate how likely it is, then it would be more likely to be cost effective. So I think, I guess the message here is, in a way, yes, it would be exciting if this is very cost effective, but it is relatively quick to do this analysis once you have the Mendelian randomization estimates and you're getting directly to the parameters that we need to make claims about cost effectiveness. Without a trial, without doing the sort of Markov cohort simulation, you can just get straight to the point and run Monte Carlo simulation and have something that's quite informative for thinking about whether you want to do a trial in this area or whether a different type of SGLT2 inhibitor should be offered. The one that was modeled, canagliflozin, is a fairly standard one, which I think even might be off patent already for diabetes, but for a new indication, they could get a patent on it, so it would be expensive. Just a standard qualifications about Mendelian randomization. There is a degree of interest, I guess, about using Mendelian randomization for policy analysis in this way. So this is a policy where we're offering everyone in society, or every man over a particular age, particular drug. What we're measuring is likely to be the local average treatment effect. So that's people whose value of exposure was influenced by the SNPs. We're probably not measuring a homogeneous effect across everyone in society, which is okay. But I think the best use of this kind of analysis of, simulating the intervention, having got the Mendelian randomization estimates, is one side of a triangle where you triangulate with other evidence. But to me, it seems a very efficient, a fairly quick way of assessing whether this might be the kind of trial you want to do, or whether perhaps there's other targets you might look at, or other SGLT2 inhibitors other than the one we studied specifically. Again, some standard qualifications. We definitely don't have power to do within family analysis with these cancer exposures, which are relatively rare. We feel a assortative mating is probably an unlikely source of bias for these kinds of exposures. And we're violating the single unit transferable value assumption of causal inference. So we don't know if manipulating cancer risk in this way would be the same as manipulating it through other means, such as environmental risk, or telling old men at risk of prostate cancer to lose some weight or exercise more, or stop. So that's a qualification to this analysis that we can't avoid. So the paper will be out hopefully this week on medRxiv. And what we found is fairly modest explanatory power for the less common cancers, which is not a surprise. But even still, for the more common cancers, which are prostate and breast, there is a material impact, which would line up in broad terms with what we would expect, and also what the simple, minimally adjusted linear regression models would find. We can efficiently do cost-effectiveness simulation. So we're leapfrogging all of those 20 years of developing the drug, doing the mouse model, doing everything else. Given that we can use Mendelian randomization for drug repurposing, we might as well then see if those repurposed drugs might be cost effective. And we can use Mendelian randomization itself to get the evidence we need to make claims about cost effectiveness. But it's definitely something that should be used alongside other ways of triangulating evidence in this area. But I think you could use this to identify a target that's more likely to be cost effective, even if it's associated with equal clinical impact. So that's it, and thanks to ICEP and Cancer Research UK and Sean and Richard. So I've finished massively ahead of time, which hopefully is the ones of setting out. Thank you.
It's great. So if you it's not sharing, then so there's questions in the room, or if people are online, we can unmute you, or you can put questions in the Q&A. So can I ask one about the liability issue? So you're looking at an actual event that happens. You're trying to obviously get costs of people who actually develop prostate cancer, not just the cost of the liability to it. But I mean, for categorical exposures, without adding another level, you're always actually estimating the effects of liabilities. How are you converting the sort of liability estimates to estimates for actual prostate cancer?
It is liability, and that's what the estimates are. They are in cases we've ascertained, I think, Sean, that it's self-report and medical records cross-referenced. So I think it is the fairest interpretation is genetic liability, but we're not measuring in anyone who isn't the case.
Yeah, the actual estimate is IV rather than two-sample summary MR. So it should be, the estimates we get should be if everyone didn't have cancer versus if everyone did have cancer averaged out.
Yeah, genetically influenced cases, yes.
Yeah. So that involves additional assumptions.
Yeah, absolutely. Can't run away from that, absolutely.
Yeah, I suppose So I mean, you could look at that by looking at healthcare costs and people who don't get, seeing as most people don't get prostate cancer with the sort of collider selection issue. Also not massive because prostate cancer doesn't relate to sort of social position, relate to all the usual things. So I mean, you could estimate the healthcare costs of the liability in people who don't get a prostate cancer would be a sort of rather nice negative control. And if those come up positive, then
Yeah.
and either you blame unmeasured collider bias, which you can always do as the sort of last resort.
Yeah.
And the last resort, or it's worrying.
Yeah, or there are potentially cases after the end of follow-up in biobank, but it's telling you what's happening in the day point when you use the follow-up. Yeah. So.
Yeah, but if you're only estimating the costs while you've got follow-up.
Yeah, absolutely.
So if you haven't developed prostate cancer, then and you're getting positive estimated costs, then you've got. I mean, I think those negative controls are really quite powerful. It's amazing how bad smoking is for 7-year-olds. If you use the smoking initiation score as an instrument for smoking. So it'd be interesting to do then.
Yeah,
maybe definitely try.
Definitely.
You possibly don't want to do it because I don't think but I think that. But I think those aren't those sort of things.
Yeah.
Or do it in women.
Yeah.
I mean, the other thing without no collider bias, then if you see the cost of prostate cancer in women.
Yeah.
That's one of the analyses that fails because there aren't enough prostate cancers in women to actually make the analysis run.
No, but I mean, but I mean, just use the SNPs and use the assumption that the same proportion will get prostate cancer. So if you see cost of the liability in women, I mean, there is a possibility that the liability in women influences prostate cancer liability influences diseases, but if it doesn't, you could get the negative control.
It's tricky with prostate cancer because it's not a perfectly diagnosed condition. So even if you're doing it in men who didn't get prostate cancer, there's no guarantee they didn't get prostate cancer, which might be having other effects.
Yeah. But if you find in the same cost, if you find in the same cost magnitude, then it's a magnitude issue. Then you know it's
it'll be prodromal cases and some confounding, as well as potentially the measure of liability that isn't informative. So
The only real drug cost you'd probably see is for the thing that makes your prostate smaller. If you got benign BPH, I know this. It's a drug. It's used.
okay. And do what? I see. So do the cost for that.
That would be a cost if you have undiagnosed prostate cancer, and you might be getting something. Never.
Tamsulosin.
Yeah.
Yeah. Costs nothing.
It does. But GP appointments aren't.
No, that's true. Questions? Open questions.
Okay, first off, like I can be a silly person, like since I do not have any backgrounds on health economics, but for me, like it seems like one of the main assumption on your model is that every patient has equivalent access to I mean, like this model looks like a model like assuming that every patient has a full health coverage. So so like I wonder that if this is applicable for other health systems, those health coverage systems, that since they will have different willingness to pay for.
So the question is, are we assuming everyone has the same access to therapy that we were modeling? And we're absolutely assuming that. And it's in kind of an NHS setting where anyone who wants the intervention can get it for free. Which is how a lot of interventions work in this country. If they're effective, they're cost effective, and they're provided, then people who want them can take them. It would be different in other settings where you would need to model the costs in a more nuanced way. And potentially there might be access issues as well. But as we said, we're assuming, you know, it's almost like putting it in the drinking water. Everyone is getting this whether they want to or not, and we assume full compliance. And there's probably no examples of that for any drug, and you know, even vaccines for COVID. You know, it just doesn't happen. But for the sake of this argument that we're demonstrating in the paper, we assume everyone gets it, everyone takes it, they all take it every day, as long as follow up and biobank. So we're getting an upper bound that reflects compliance and availability for a drug that's relatively cheap, £42 a month or something. So it is an estimate that's certainly specific to the NHS in England and Wales, which is where we drew our outcome data from as well.
I wondered if you thought about whether you could, I don't know, but start looking at if it was only given to people who had other measurable risk factors that made them higher risk of getting prostate cancer in the first place, and whether that would change the outcome.
Yeah,
Best one would probably be, I think
Age.
ethnicity. No, I was going to say ethnicity rather than age, because there's a massive degree of variation in prostate cancer incidence, depending if you're Jamaican or Asian. Like there's a 40 times difference or something. I still doubt it would be cost effective based on
it probably won't be.
the very limited effective qualities that prostate cancer seems to have on average, and the very small healthcare cost.
Yeah.
So you really need to increase the prevalence in a particular group by a substantial amount for it to become cost effective and reasonable drug price.
Yeah, and the effect of age is such that it makes it more likely to be cost effective, but it's still not remotely cost effective. Chris's paper does actually show that SGLT2 inhibition helps for aggressive cases of prostate cancer as well. So conceivably, in the future, maybe there's a trial, then you don't have the intervention we modeled in the paper where it's population-wide and prophylactic, but you get diagnosed and then you say you need to take this pill every day. And that's a different exercise to the one we've done, which would be, I think, a little bit outside of this framework, but absolutely something you could do. And I mean, what matters in prostate cancer is obviously how aggressive it is, because everyone, you know, most men get tumors if they live long enough, but it doesn't affect anything. It definitely doesn't affect overall survival, which is why, as Sean said, the quality impact, which includes mortality impacts, is quite modest. And if we looked at a more aggressive cancer, then, you know, it becomes different. But then the aggressive cancers might not be the more common ones, and then would you do a population-wide intervention to stop that, or just wait until someone presents and say, I've got, you know, yes, you have a tumor here, immediately take this with your breakfast.
So it's another thing I've, you know, found in polygenic scores. Prostate cancer is the one case where the polygenic score is the pin-off of prediction. For prostate cancer, with age, it's the inverse of what you imagine. The cost effectiveness is in the young, because the young have the Frank Zappa style prostate cancers, which kill you in 2 years. So the strata, which would be sort of non strata, would be people with very high genetic risk at lower ages, because you save a lot from preventing or delaying, sort of Frank Zappa
And aggressive cancers.
as opposed to, you know, I mean, at 80, it doesn't surely be high prostate cancer diagnosis.
The actual prostate cancer treatments are expensive. It's just most people don't get them.
Yeah. And I didn't know about I didn't know that you could, if you've got something off 80, so you're saying you can actually get, so simvastatin suddenly found to cure something else.
If it cures Alzheimer's, I think you get a patent. That's my understanding. You can patent it for the new indication. So you might want to buy shares of people who make SGLT2 inhibitors, and then it cures prostate cancer. So,
wouldn't you get it prescribed for diabetes?
or you get a friendly doctor to prescribe it off indication, off label.
Yeah.
That's, yeah. So then your costs is all your costs of counterfactual estimates is the counterfactuals not allowing them to, you know, the price.
But you know, if if we had a more aggressive cancer that had bigger quality impacts than the one we found. So maybe the statins on ovarian cancer that James found.
Yeah.
Very cheap drug, and if it's a big enough impact, and ovarian cancer a bit more the promising candidate potentially, then calculus switches. But once you have the data, the analysis is not too tricky, and it would, if you're going to a funder, you can say we've got the evidence that this repurposed drug could be really effective and it's potentially cost effective. That seems quite compelling for a trial or some other study design they might fund you on, as opposed to sort of wishing and waiting, and then it's horrifically expensive.
Any more questions? So thanks for joining again.
Right, thanks very much.